Welcome to the Oxford Cath Lab. My name's Sam Dawkins. Thanks for joining us for this tricuspid case. Let me start by introducing the team. I'm assisted by Stuart. Doing the imaging today is Jim Newton with USMA. Doing the anaesthetic is Dave Piggott, assisted by Roberto and Dovi. The Cath Lab team are Richard, Merlin and Wendy. From Edwards we have Alison, Anya and Roma. And from the stock answer doing the filming we have Martin, Sean and Phil. So let me show you where we've got to so far. We have venous access. That was ultrasound-guided micropuncture. We've got 2 ProGlides. What we will do is put a wire into the SVC in just a second. But before we do that, let's just go over to Jim. Jim, do you mind giving us a tour of the tricuspid anatomy?
Thanks, Sam. So I'm just going to show you the key views in this gentleman's anatomy. So we're starting in a 0-degree 4-chamber view. You can perhaps appreciate he's got a rather stiff-looking hypertensive left ventricle. His mitral valve is healthy, and I can tell you there's no mitral regurgitation. You can already appreciate the tricuspid annulus is dilated. That measures 5.9 centimeters in the 0-degree view, and we can see a captation gap there between the septal and anterior leaflet. We're going to put some color on there, and we can see the TR jet is central. The vena contracta measures 8 millimeters, so it's definitely severe TR. Looks to be one single jet rather than any multiple jets coming up through the valve. Color off, please. The working view for most of the procedure is this short axis mid-esophageal view, where we're centering over the aortic valve, and we're looking for a view where we can see the tricuspid leaflet in a view that's equivalent to the biconchral view of the mitral valve. And here we have the septal leaflet closest to the aortic valve, and then the anterior leaflet over to the left, and we can see the RVOT and the pulmonary valve on the right. And again, the color on here will show us a nice central jet arising between predominantly the septal and anterior leaflets in this view. And we're going to put biplane on here and line up through the jets. It's best to use that control. Bring the color down. And again, this is our sort of clip alignment and grasping view. So we've got our septal and anterior leaflet, and we've got our, on the right-hand view, the septal leaflet and the color jet. And again, the vena contractors, 7 to 8 millimeters. The other key view then is a transgastric view. So I'm just sliding in further down to the esophagus and into the stomach. And we're looking for a nice en-face view of the tricuspid valve. It's usually somewhere between 40 and 70 degrees, obviously depending on the amount of distortion of the right ventricle. And we're hoping to find a view where we can try and appreciate all 3 leaflets, sometimes 4 leaflets of the tricuspid valve, and clearly understand where the jet is coming, because this is a view you're going to use to orientate the clip correctly to grasp your intended leaflets. And if I just find this view here, okay, starting to come in now. You can see this gentleman's got a cyst in his liver coming in on the left there. So here we're seeing the anterior leaflet at the bottom of the image, heading towards the right ventricular outflow tract. The anterior leaflet in this case is large. There's a cleft separating the anterior leaflet into 2 portions. The posterior leaflet is nearest the TOE probe, so at the top of this image, and then the septal leaflet is over on the right-hand side. And our intention here is probably to aim for clipping between the septal leaflet and the anterior leaflet, probably the most anterior cusp initially. And we're just going to put some color on here, and we should see the color jet clearly appearing in that captation defect in the middle there. Whether we'll be able to treat this with just 1 clip, we'll assess carefully after the first clip deployment. It may well need 2 with 1 each onto those anterior cusps.
Thanks, Jim. Well, that nicely illustrates some of the variability of the tricuspid anatomy that we encounter. Interestingly, his TR is now quite a lot worse than it was when I saw him in clinic. And his symptoms are hepatic congestion and peripheral edema. He's been admitted several times now with peripheral edema. So what we're going to do is put a wire into the SVC. So we'll use a multi-purpose to steer up. That's in the RV. Sometimes a little bit fiddly.
Bouncing off the septum there.
Yeah. There we go. So that's in the
SVC.
SVC. So this is a multi-purpose catheter. Thanks, Joe. And what I'm going to do now is put a super stiff wire in the SVC, which is our rail to deliver the Pascal delivery system. Okay, so that's up in the SVC. We've got a nice loop there. So we're advancing that up into the SVC. My experience with these procedures is it's better to start high and come down. It's quite difficult to gain height once you're too low. So what I'm going to do, I'm going to put the port here on the top, which is the orientation we need for tricuspid procedures, as opposed to 4 o'clock or so for mitral procedures. I'm watching the bicable, well, not quite bicable view that Jim is showing me there. And I'm just going to come up into the SVC, make sure I'm not interacting too much with the septum, which I don't think I am.
Very nice and parallel, Sam.
Park up there nice and high.
Up in the SVC, yep.
And then what we can do is get the wire out. Thanks, Joe.
There's the end of them.
So that's just guide, Jim, for you to see
nice.
there.
Well in the mouth of the SVC, Sam, nicely lined with it.
So that's a really nice view for this part of the procedure, because I will be able to see the implant coming out and can make sure that it's nice and clear, it's not catching anything, and that's true also of closing the implant. So here's the Pascal device itself. So once again, the guide port is at 12 o'clock. Introduce the implant, push it in, a couple of handfuls of implant catheter, and then just like with a sapien valve, we strip off the introducer. And then we're going to aspirate and flush the guide. So we do that after we've introduced the implant catheter. So that's the guide flushed. We gave heparin after we got vascular access. We're aiming for an ACT of around 300. So now that I'm coming up to the tip of the guide, you can see the implant just coming out of the end on the TOE there. And what I'm going to do now is essentially unsheath. So I'm keeping the implant in more or less the same place, watching carefully on TOE, and then pulling the guide back. The guide needs to be back onto that hard line that you see further down the fluoro screen. Just there. And now we can start forming the implant. So we're just going to watch carefully to make sure we're not catching anything. I don't think we are.
No, you're nice and free in the SVC, forming nicely.
And you can see that also on fluoro as I close.
Close well there.
We're not catching the septum there.
No,
Once we're closed, we're going to lift the clasps. And now we're going to steer down towards the valve. I'm just going to advance a tiny bit, Jim, just so that we've got a bit more room. Richard, can we go to RAO, maybe 15 degrees or so? Now, there's always a little bit of experimentation for this bit, because the right heart, the way it sits, can be quite variable. Usually, we can just flex down, and we'll watch carefully to make sure we're not catching anything. If I'm too high, I would just come back a tiny bit. But it looks like, if you watch the fluoro, we're coming down very nice and freely.
Yeah, looks good as well on the TOE.
And once we're pointing down at the valve, we will switch views to work out where we need to be. So I find it's quite helpful to start by making it look more or less what you expect it to look like on fluoro. So if you look at the fluoro now, we're pointing down and right, which should be towards the RV apex. Then we can go over to the TOE views, and we're not quite at the standard views because I'm quite high above the valve, but in the left-hand view, you can see I'm quite aortic being on the right, rather than posterior, which is on the left. So I'm just going to pull the whole device back a bit to get off the aorta. So that's come back very nicely and translated very nicely. And then in the right-hand view, everything looks very nice. We're pointing straight through the valve, and the trajectory looks good. So I'm going to get closer to the valve so that we can then fine-tune our position. And what we will do now is just sort out the trajectory one by one. We want to be going straight through the valve in both planes. So starting with the left-hand plane, if I just, the implant is closed now, so perfectly safe to advance and come back. So, Jim, I think I'm diving a bit posteriorly.
You are, aren't you?
Happy with
Yes.
that? So I will take off a bit of guide flex. Keep an eye on fluoro, just to make sure it all looks free. So that looks more straight through the valve, doesn't it?
Yes, you're heading now into the sort of body of the RV down towards the apex rather than the posterior wall.
So that's better. I pulled the whole thing back because I unflexed to stay more or less in the middle of the valve. So AP, I think the trajectory doesn't look too bad.
That's
and then
good.
If we look at the other side, the right-hand view, this is showing septal and anterior. Septal is the top leaflet, anterior is the bottom leaflet. If I advance through the valve, all looks pretty good to me. What do you think, Jim?
Looks very well aligned, doesn't it, with the plane of the valve, heading straight for the RV apex.
Yeah. Might be worth just talking about the steering. It doesn't look like we're going to need too much of it for this particular patient, but the challenge we often have with tricuspid cases is that we are septal hugging. So that means that the implant is coming down from the top of the screen and crossing the valve at a diagonal. And just to show you how we fix that, if the port is at 12 o'clock, you get a relatively pure movement. If I just show you now, so I'm flexing the guide now, and you see how so it's quite making it difficult for Jim here by moving, but do you see how the guide is moving across in the right-hand view from top to bottom? So it's now more on the anterior side of the right atrium. And if I take that guide flex off, do you see it corrects? So we don't need that for this patient, but it just illustrates that that is available. The other things that you can do is by changing the clock and anti-clock of the guide or changing the position of the port related to 12 o'clock, you can gain and lose height. So by using guide flex and moving the port, you can gain height, lose height, and fix septal hugging and fix lateral hugging. So you can sort out most issues that you can have in these patients. But I think we hope we won't need to do any of that with this chap. So the next step is to open the implant. So this is a Pascal ACE. This open, yeah, there we go. So that's now open to capture ready. And it's not far off. We can see that it's not far off already because you can see both clip arms in the right-hand view. The first thing we're going to check is the clasps. So normally the port side is the septal side. So I'm just going to drop that down now, which it is. So you can see the septal dropping nicely there. And then we'll drop both together and then come back up. I tend to leave the pin out just because we tend to use independent grasping for these cases. So just to go through the controls, so I've showed you how we use the steerable guide. That's for fixing septal hugging and addressing height issues. The fin, which is here, would normally be at 2 o'clock or so, just like for mitral. And if we clock, if you look at Jim's view there, I'll just come back off the valve a little bit. If you look at Jim's images there, so we'll get the TOE on the screen. If I clock, we go septal. If I anti-clock, we go the other way, lateral, which in this case is towards the anterior. And as I showed you a second ago, if I push into the patient, we go towards the aorta. So that's looking at the left-hand view in Jim's TOE. And if I pull out, we go posterior. So that's how we correct our movements. Orientation doesn't look too bad, Jim, but should we...
No,
this patient has a nice 3D, doesn't he?
He does. We'll have a go, see if we can get a 3D view.
So normally 3D isn't actually that much use in tricuspid because you can't see the leaflets. Certainly before we could see the leaflets. It might be that my implant is causing too much shadowing. But we're expecting to go septal anterior here, which should be a 2 to 8 o'clock orientation.
So just to orientate you on the 3D, the aortic valve here in the middle of the screen, left atrium at the bottom, atrial septum, septal leaflet of the tricuspid valve, and we can see the clip orientating between the septum and the anterior leaflet, but there's too much shadowing here to really see the leaflet, so we'll do the orientation from the transgastric view I showed you earlier.
So unlike mitral, where we tend to jump between Viacom LVOT and 3D on FAS, for these procedures, we tend to jump between the mid to deep esophageal views and this short axis transgastric. The short axis transgastric is really the only place where you can be sure where you are in the valve. In the mid-esophageal views, you can be caught out by how commissural you are or how in the middle of the valve you are. So we tend to jump back and forth quite often just to make sure that we're where we think we are. So this is quite a challenging view because we're above the valve. So to get both the valve and the implant into view is difficult. But what I want to do at this point before we cross is to get more or less where we need to be. So we're aiming for A1, right? The anterior leaflet of the anterior leaflet, if you see what I mean. Anterior part of the anterior leaflet. So that's going to be a 2 and 8 kind of orientation. So not too bad. What do you think, Jim?
No, it looks okay. It looks like you're favouring the middle part of the anterior leaflet at the moment, but we can cross and see where you end up.
So I think I'll just fix that a bit now, just so that we're not having to move too much under the valve. So I would like to go more into the anteroseptal commissure. So to do that, I'm going to push the whole device into the patient, and you can see that tracking across nicely.
That's nice.
And then perhaps get off the septum a bit, so a little bit of anti-clock on the steerable. Difficult to tell from this position, but I've anti-clocked a tiny bit, Jim. Oh, sorry, clocked just a tiny bit, Jim.
No, that looks very promising, Sam. You're definitely in the right commissure now.
Good. So we've got to more or less the position we want to be in. What we'll do now is go back to the esophageal views, and I'll close the implant and cross the valve. So I tend to close the implant for crossing just because it means you're much less likely to interact with cords, which can cause trouble when you're trying to grasp later on. So I'm just crossing very slowly, making sure I'm not diving one way or the other. I just clocked the steerable a tiny bit there just to get a tiny bit more septal. So we're now, looks like we've gone straight through the valve.
You have, yeah, nice and cleanly
We're underneath. And I will now open the implant under the valve and come a bit closer to the valve, and then we'll recheck the transgastric views.
Yeah, so you're nicely open there, and just watching you weren't tangled up in any of the cordae there on the right-hand side, but you look to be free. So we'll go back to the transgastric view.
Now the thing I'm just wondering, Jim, is that septal leaflet is a tiny bit curled at the tip, isn't it? Which might require a bit of manoeuvring to capture, but we'll see how we get on.
This orientation looks good to me.
Yeah, it's
sitting nicely on the septal
230, 830, isn't it?
And we're on the correct part of the anterior leaflet. We're quite close to the separation between A1 and A2.
What about if we anti-clock a touch and go a bit more commissural?
Maybe sort of
something like that. So
20
let
degrees
me
anti-clock.
Anti-clock a tiny bit. The transgastric, now that we've got the guide in position, is quite difficult. There's quite a lot of shadowing, but we can see where we are. So I've anti-clocked a few degrees, and I'm going to go a tiny bit more into the septal anterior commissure.
Yeah, that's looking promising.
So something like that, Jim, what do you think? Anti-clock a tiny bit more, maybe?
Yeah, another 10 degrees anti-clock.
Okay.
Okay, yeah, that's translating.
So that's more or less where we want to be. We'll go back to the esophageal views.
So we can see our target and we can see the clip arm open.
So I'm going to go a little bit deeper.
Yep.
Quite a lot anterior. Actually, that transmitted very nicely, didn't it? Quite a lot more anterior. Looks like we're well in there.
Well in there, yeah.
So that's the class down.
Yep, happy with that.
Okay, so we've got anterior.
And we can see our septal target now.
So septal is a bit curled at the tip.
It is, isn't it?
Almost always we use independent grasping for tricuspid. You might get away with not using it for mitral, but tricuspid almost always we do. So I'm just making sure the implant is open. Richard, do you mind just going PA for a second? I can't see on fluoro whether we're properly... yeah, we are about right there, I think, actually, aren't we? So now I'm just going to put a load of septal torque on, and we'll see if we can get the septal to sit in there. I'm just opening the implant a bit too. So very, very tip, but not enough. So I'm opening a tiny bit. More septal torque. Ah, very close. That's probably in, isn't it? Or it's coming in and out, isn't it, I think?
Yeah. It's
So I'm just going down a bit, just
dropping
making
off at the end.
small corrections just to try and... So it's just curled, isn't it?
Yeah.
So we know we're not far off, so I'm just going to come off the septal a bit. I'm going a little bit deeper, clocking a bit more.
That's it.
I think we got that there, didn't we?
You did.
So you'll notice there that we're swinging quite a lot. So we started very anterior and we've swung quite septal. Our experience is that that's a very safe maneuver, and we do it all the time in the tricuspid position. So now I'm going to take my hands off and let Jim have a look in the transgastric view. Make sure that we're happy with the orientation. The transgastric view is often the best view to see how much leaflet you have. And if we're happy with orientation and the amount of leaflet, we'll close the implant there.
The orientation looks reasonable, doesn't it? We're nicely on the septal.
Yeah, we're probably
leaflet.
On A2 rather than A1.
We are,
we?
yeah, but that's maybe not, not going to be a bad thing. It's frustrating in him that the artifact gets right in the way of imaging the leaflets in the clip.
So we're not quite where we'd planned to be, in that we've probably got a good grasp of septal and A2, so the more posterior of the two parts of the anterior leaflet. Given that it's such a good grasp, I would not be averse to trying that, but we'll just let Jim finish his assessment.
So I can see the septal leaflet coming very nicely into the clip there. You can see the septal,
well in there, isn't it?
Septal coming down into the base. It's quite a bit harder to get a clean view of the anterior. I'm going to just try for a long axis. So it's going to be difficult to prove how much anterior you've got on, Sam, and of course it's the risk of opening to optimize as we fall off the anterior. So again, with the orientation looking good, I'd be happy to watch it close and see if the anterior gets pulled across as you close.
Yeah, I think so. So the clasps are both down. I've taken off, I put a load of septal steering on to pick up the septal, so I've neutralized that. We're now back to hopefully no tension in either direction, and I'm now slowly closing. We'll watch the leaflets hopefully be drawn in, and if the anterior comes out, we know we didn't have enough in the first place. So that's closed nicely.
Okay.
Septal looks great, doesn't it?
Septal looks good, yeah.
Anterior is certainly in, but we'll now let Jim assess that fully.
Yeah, so we can see the anterior leaf there is definitely held up by the clip, definitely still attached. And now we just repeat our assessment really from the baseline again. So I'm going to look at 0 degrees, and again I can see there the septal and anterior leaflets both parallel and running into the clip. And we're going to put some colour on there. So we can see there's some TR coming up behind the clip, so we've got to try and work out where that is. It's probably going to be between the septal and the more posterior part of the anterior, but we'll find out when we go transgastric. And now we're going to go to our 60-degree view. And X-plane there, please. What's quite helpful here is to slowly X-plane from outside beyond the clip through the clip. So we're now coming through the clip, so we can see the unclipped leaflets there on the right. Walking our way slowly on the biplane, now coming into the clip, and again I can see both leaflets heading into the clip nicely there. Now we're going through the clip onto the septal side, and leaflet mobility returns. So looks a nice grasp so far. The residual TR looks to be mostly on the more posterior side. So now we're going to look transgastric. So that's a nice shot there. So we definitely can see anterior leaflet pulled into the clip there. We've got a sort of double orifice bow tie looking valve now, which is different to how we started.
That's very reassuring for the amount of tissue that we've got, isn't it, Jim?
Yes. And there we can confirm that the residual jet is on the posterior side.
And that's an important point, because you saw that shadowing was a bit of a challenge already. Generally speaking, you want to deploy your implants from far away from the probe towards the probe. So if we were to try and put another implant more anterior, so further down the screen, that would be very, very difficult because of shadowing. But putting another implant more posterior, which if we were going to do that, would be where we'd need to put it, should be a little bit easier in terms of the imaging, at least.
So in this view, coronary sinus comes in at the top of the screen, runs vertically down towards the tricuspid valve. And again, I'm just looking at both leaflets, look nice and stable, nice and orthogonal to the clip. So it looks promising, Sam. I think it's in a good position. I think the orientation's good. We're definitely on septal and anterior. The only thing I can't demonstrate because of the shadowing is how much anterior leaflet's in, but it's been pulled across nicely. It looks stable on the clip. I think this is a good initial position.
Yeah, it looked good in transgastric, didn't it?
It did.
For amount of tissue. I think we can be reassured by that the residual jet is mostly posterior to the first device. I don't really see there's any value in moving this onto septal and A1.
No, I agree. And if there was a big anterior jet, we definitely would move, but I've not been able to demonstrate that. So I think
good.
It's a
Okay,
good
well
position.
we'll release this implant then. So I'm now removing the blue release cable, which with ACE usually is quite a few turns. Okay, I'm going to come off in just a second, Jim.
Okay.
Off there.
Off and stable.
That looks nice and stable on fluoro. So I'm going to get the implant catheter back and pause and let Jim have a look. We do quite often see after release, as the tension is released from the implant, that the residual mitral or tricuspid regurgitation goes down a bit, but we always do a complete reassessment here.
So the clip looks very stable indeed. I can see again both septal and anterior leaflets nice and flat heading into the clip. No obvious leaflet movement relative to the clip. Put some colour on. So on the left-hand view, what I'm really trying to see is there any TR of note between the clip and the aorta? Doesn't seem to be. The jet looks to me to be coming on the posterior side. So if we put the X-plane now through that jet, just there, and we can see the jet there on the right-hand side. So we can see it's adjacent to but separate from the clip. And again, you can see the vena contractor now is much smaller. We've probably brought this tricuspid regurgitation down by at least 50% just in terms of the jet area, but we'll again have a look transgastric view in a moment. So here I can see the clip sitting on the septal leaflet well, and I'm just trying to demonstrate the anterior attachment. So again there you can see a sort of double orifice valve now with the anterior nicely pulled across. I'm going to put some colour on here. And there's the residual TR on the posterior side.
What's your experience of these patients in clinic, Jim, in terms of how much TR you need to remove for them to feel different?
Yeah, it's quite different to the mitral side, isn't it? Where we want to get the mitral regurgitation down to mild or better. With the TR, I think if you get the regurgitation volume down by even just 20 to 30%, the symptomatic gain is huge. And some patients, even when you leave them with what looks like, moderate or moderate plus TR, if you started with torrential TR, the dramatic improvement can be, quite striking. So I don't think we need to aim for quite the same level of regurgitation reduction as we do on the mitral side. Having said that, we rarely achieve a good result with one clip. Sometimes we do, but it's usually two.
And the usual pattern with these patients is they go home same day or next day, and usually within the next couple of days they have a fairly major diuresis. and then when you see them back in clinic, you can back off the diuretics a bit. So we could certainly put in another implant, but it's always, with any, true with mitral as well, worth weighing that up against the cost. That it's always slightly more challenging putting in a second implant. We don't want to touch the first clip, but we want to get as good a result as possible.
We're just going to Doppler the hepatic vein again, see if we've...
I'm just going to come back a bit with my steerable, Jim.
So we've now got forward flow through a whole duration of systole. We had definite clear flow reversal before, so we've gone from severe TR to moderate or better, and I'm going to make a final judgment based on the colour in this view. So this is, for me, as a short, relatively low velocity jet. I can't see a dramatic vena contractor. Have a look again at 60 degrees.
So I think what we now need to think is, if we were going to put in another implant, where would we put it? And is there enough leaflet where we might go? I have to say I'm not convinced that we would need to put another implant in here.
No, I'm at the same point. I think this is a good result.
So I'm quite reassured by these images, Jim. We've taken severe TR with hepatic vein flow reversal, reduced it to moderate, or perhaps even less than that, with forward flow in the hepatic veins. There is a residual jet just on the posterior side, but it's certainly not severe. As you say, short in duration, it doesn't really go anywhere. We could perhaps chase that, but I'm not sure there's any major need to. What are your views?
No, I agree, Sam. And I think the difference we've made here in the amount of TR and the regurgitant volume is high, and the further gains by chasing the small jet are low. And of course, there's always the hazard of potentially interfering with the first clip, potentially distorting the valve anatomy. I think we've gone from definite severe TR with flow reversal in the hepatic veins to normal flow, and I think this is mild to moderate TR, and I'd accept this.
Good, and it illustrates the use of independent grasping. I think that would have been quite challenging without it, wouldn't it?
I think it would have been extremely difficult, actually, that ability to swing across and get right under the septal. And we always tend to try and grasp anterior first, and then the septal's always a little bit curled, isn't it? And swinging across makes such a difference.
Good, well, we're going to stop there. Thank you very much for joining us. We are going to finish the procedure. We'll secure the ProGlides, and the patient should go home within the next 24 hours or so. That procedure took just over an hour. They're quite variable. Sometimes they can be quicker than that. Sometimes, if the imaging is hard, they can take a lot longer than that. But a good reduction in the tricuspid regurgitation from severe down to less than moderate.